Okay, I will start in a bit.
Would you like me to share my slides?
No, please. I will just introduce you all and introduce the course, and then we will go to your speech. Thank you very much. Okay, ladies and gentlemen, hello and welcome to the third session of How I Treat Autoinflammatory Disorders course, a progression to How I Treat series. I am Dr. Kosa Asnashari, Assistant Professor of Pediatrics at Children's Medical Center, Tehran University of Medical Sciences, Iran, and the head of the executive team for the present course. Before we begin, I will briefly introduce How I Treat series. The series are educational programs under supervision of the leading house for Iran North America academic partnerships. Each of these programs try to provide information on basic knowledge and clinical experience related to treatment of a disease or an aspect of a disorder. Our course, How I Treat Autoinflammatory Disorders, includes 8 to 10 sessions during which we discuss different aspects of autoinflammation, including pathogenesis, diagnosis, treatment, patient education, network development, and some special cases. Our goal is to discuss the latest updates on autoinflammatory disorders by the help of novel experts from around the world, namely USA, Germany, Turkey, and Iran, as our speakers, and to provide physicians, pediatricians, immunologists, and rheumatologists with an opportunity to make use of such discussions. In the light of these efforts, we hope to unravel the baffling nature of autoinflammatory disorders, leading to the relief of those affected. I shall thank Dr. Wahid Ziai, head of our scientific committee, professor of pediatric rheumatology at Children's Medical Center, Tehran University of Medical Sciences, and the president of Pediatric Rheumatology Society of Iran. Without his full support, holding the course at its best would not have been feasible. We would also genuinely thank Dr. Marjan Yaghmai, head of leading house for Iran North America academic partnerships, for her kind support. I would also like to express my highest gratitude towards Professor Sumaira Farman Raja, Professor of Rheumatology and convener of APLAR Pediatric Rheumatology Special Interest Group. Our course was endorsed by APLAR thanks to her kind support. The world-known Association of Asia-Pacific League of Associations for Rheumatology, or APLAR, strives to shed the lights of knowledge and awareness upon the mysteries of rheumatology in the Asia-Pacific region. APLAR's mission and goals focus on providing advanced care to the patients with arthritis and other musculoskeletal diseases through the continuing professional development of members, increasing the understanding about rheumatic diseases, patient advocacy and empowerment, and encouraging research in the field of rheumatic diseases. Before I proceed to introducing our dear speakers, I shall explain the process of receiving our course certificate to you. In order to receive a certificate for each session, you need to register via a Praise to Raise website. The link can be found here in the chat group, in my slide, and in the session's poster. You can also register for the whole course and receive a certificate of attendance in an international autoinflammatory course approved and validated by Asia-Pacific League of Associations for Rheumatology, or APLAR, Pediatric Rheumatology Society of Iran, Iranian Rheumatology Association, and Tehran University of Medical Sciences. For those who were not able to attend our previous sessions, there is a possibility to view the video of the session on the website, answer to the post-test, and receive the certificate for the session. We decided to provide course certificates to all the ones who either participate in the session or watch the video and pass the post-tests, as the goal of our course is to educate the participants. We will now begin our session entitled Network Development for Autoinflammatory Disorders and Patient Education. We are honored to have 3 of the most outstanding experts in the field from the United States, Professor Sivia Lapidus, Dr. Mariana Correia Marques, and Karen Durrant. Professor Sivia Lapidus is a pediatric rheumatologist at Joseph M. Sanzari Children's Hospital, Hackensack Meridian Health, USA. She is the leader of the Childhood Arthritis and Rheumatology Research Alliance, or CARRA, Autoinflammatory and PFAPA work group. Dr. Lapidus has been drawn to clinical care and translational research in autoinflammatory diseases since her postgraduate training under the mentorship of Dr. Daniel Kastner, the founder of Autoinflammation at the National Institutes of Health. She graduated from Barnard College, Columbia University, and received her medical degree from the State University of New York Upstate Medical University. From 2014 to 2017, Dr. Lapidus was the vice chair of the CARRA SVARD, or Scleroderma, Vasculitis, Autoinflammatory, and Rare Diseases Committee, acting as leader of the CARRA PFAPA work group since 2013 and contributing as co-leader to the CARRA Kawasaki disease work group. Additionally, Dr. Lapidus is a guest researcher at the National Human Genome Research Institute at the National Institutes of Health, where she continues her research in the pathogenesis, treatment, and genetics of autoinflammatory diseases with a focus on PFAPA. Since May 2020, Dr. Sivia Lapidus has been the leader of the task force of the Hackensack Meridian Health Network dedicated to optimizing treatment, care, and research for MISC. Additionally, she has been a member of the American College of Rheumatology MISC Task Force, where she contributed to generating guidance for the care of patients who are suspected of having MISC, as well as other COVID-related hyperinflammatory conditions. Our next speaker is Karen Durrant, RN BSN. She is the president and founder of Autoinflammatory Alliance, a nonprofit organization dedicated to improving awareness, care, and treatment for patients with autoinflammatory diseases, in addition to her role as a pediatric registered nurse in San Francisco, CA. She is the patient organization's representative for the International Society of Systemic Autoinflammatory Diseases, or ISSAID, the CARRA Autoinflammatory Disease Working Group, the patient representative, and is a member of the patient research group advocating for autoinflammatory diseases with the COVID-19 Global Rheumatology Alliance. Karen has helped to facilitate a number of collaborative research efforts that have brought a global team of medical experts together to establish consensus recommendations for the diagnosis, care, and treatment of interleukin-1 mediated and interferon mediated autoinflammatory diseases that have been presented at the ISSAID Periodic Congress. Karen had 3 children. One child has a complex systemic autoinflammatory disease, and another child has a different rheumatic disease. She's also a founder and moderator of a few private patient communities for over 7,200 autoinflammatory disease patients and caregivers, and is a moderator for Rare Connect for autoinflammatory diseases. And our third speaker is Dr. Mariana Correia Marques. Dr. Mariana Marques is a physician from Brazil. She did her medical school at the University of Brasilia and completed her residency in pediatrics at the University of Sao Paulo. She did the second residency in pediatrics at the Boston Combined Residency Program. She completed her first year of pediatric rheumatology fellowship at the UPMC Children's Hospital of Pittsburgh, and she recently transferred her fellowship to the Children's National Program, combined with the National Institutes of Health. Dr. Marques has been co-leading an international multi-center study to validate the Autoinflammatory Diseases Activity Index for PFAPA, along with Dr. Nadine Saad, Dr. Fatma Dedeoglu, and Dr. Sivia Lapidus. She has recently joined Dr. Michael Ombrello's lab within the National Institute of Arthritis and Musculoskeletal and Skin Diseases, where she will pursue translational research in systemic juvenile idiopathic arthritis. I would also like to thank Dr. Dedeoglu for her support and presence in these sessions. She's one of the most elite pediatric rheumatologists in the world, and we are truly grateful for her strong support in coordinating our sessions. And I want to ask you, our dear participants, to share your ideas and ask your questions in the chat forum. It is better if you address your questions to me, Kosar Asnashari, as the moderator. Our first speaker is Professor Sivia Lapidus. We are honored to have you here, dear Sivia, and we are all ears. Thank you.
Wonderful.
Thank you very much.
I'm just connecting. Welcome, everyone. Good morning and good afternoon, depending what part of the world you're in. Can everybody see my slides?
Yes, clearly.
It is a true honor to be here today to represent network development for autoinflammatory diseases and setting the framework for Karen Durrant's and Mariana's fabulous talks on some other details of autoinflammatory networks and patient educations. I will try to also, of course, include some treatment information, given the title of the series. I included a picture here. Sorry. I included a picture here of a bird, because I feel that birds always symbolize flying together, migrating together, making progress in a very gentle, productive way. And this is a picture of a network, as you can imagine. So I was trying to bring it to life. Just figuring out how to advance my slides. So disclosures, I have no financial disclosures. I just wanted to say that just because we work with Childhood Arthritis Rheumatology and Research Alliance, which is a North American organization. A lot of what we do does represent North American efforts, but we are trying to collaborate as much as possible with the Europeans. And I know there's many other talented speakers coming from other parts of the world, but I just wanted to say that we're really reflecting most of the work in North America, not to negate anything, all the productivity in other parts of the world. I just want to also mention, of course, these are rare diseases, especially in North America, and medications discussed are not necessarily approved by our regulatory organizations. So the objectives today, I hope when you leave this talk, you'll be able to understand the rationale and benefit of developing CARRA consensus treatment plans, in particular regarding the treatment of periodic fever, aphthous pharyngitis, and cervical adenitis, PFAPA. I'm going to try to highlight the efficiencies, international collaborative opportunities, and significant research advances feasible through network development. And in the process, I'm going to feature our very exciting fellow ambassadors, including Mariana Marques, who will be a speaker, to explore emerging clinically relevant data generated collaboratively in rapid real time in response, partially, not always, to the COVID-19 pandemic. So this is I believe this picture came straight from Karen Durrant's website. I could be wrong, but it's a picture of what children said about their periodic fever syndromes. And it's an 8-year-old girl and a 5-year-old boy who drew monsters. So this is a very important problem for patients, for the kids, for the adults who suffer with it, for their parents. And it's a very complex program, and we're constantly, I call it unraveling the tangled web of autoinflammation. And we do it very slowly but surely, one piece at a time. And there's always strength in numbers, which is why I think it's so amazing that this talk was conceived, these talks were conceived. I'm going to just give a little background about the Childhood Arthritis Rheumatology Research Alliance. The easy name for it is CARRA. And it was organized, really at the beginning of the 2000s and has grown substantially. And we're very honored to be included in CARRA. CARRA's mission and vision is to conduct collaborative research to prevent, treat, and cure pediatric rheumatic diseases of all types. And their dream is really to have a world free of limitations from pediatric rheumatic diseases. So, since the birth of CARRA, a variety of autoinflammatory diseases have been captured in a variety of work groups. There's the overall umbrella organization, which used to be called scleroderma vasculitis, Autoinflammatory and Rare Diseases, now is called the very simple Rare Disease Subcommittee. Under that umbrella, there are many related work groups. We started off as the PFAPA work group. We're now called the PFAPA and Autoinflammatory Disease Work Group to include more diseases under our rubric. There's also the very important Kawasaki Disease Work Group, the Chronic Recurrent Multifocal Osteomyelitis Work Group, the Autoimmune Immunodeficiency and Monogenic Disease Work Group, and the Autoimmune Encephalitis and Inflammatory Brain Diseases. That's all under the Rare Diseases Subcommittee. The Systemic JIA and Cross-Cutting Committees and the Translational Research Committees also do parallel work in autoinflammatory diseases, but are not under the umbrella of the Rare Disease Subgroup. You do not have to memorize this. I just wanted to give you a framework for the efforts of autoinflammatory diseases. Now, in 2013, the very esteemed Dr. Dedeoglu and Dr. Donald Goldsmith had a dream, and their dream was to have an autoinflammatory disease work group in CARRA. And we all got together, and there was a lot of limitations. There wasn't financial support. There were only a handful of people at that meeting. There was the National Institutes of Health in the US that does phenomenal work on autoinflammatory diseases. And we were trying to figure out what our niche could be, how we could contribute with our limited resources, and how we can make progress, considering the framework of that time in North America. So the very important decision was made to focus on diseases that were not covered by NIH, maybe by Eurofever as much. And we decided to focus on PFAPA because it is the most common recurrent fever syndrome that we see in North America. It also is very common, obviously, in other parts of the world. And we also decided to focus on chronic recurrent multifocal osteomyelitis, autoinflammatory bone disease, because there was not a large effort to do that in a collaborative way in North America at the time. So that's how we started. And then Dr. Jonathan Hausmann and Dr. Dedeoglu and Dr. Donald Goldsmith did this very interesting presentation looking at autoinflammatory diseases. They called it a very nice title, The Past, Present, and a Perspective for the Future. So I thought that was a great way to explain what was going on in our world, in our part of the world. And you can see here on the left, that's Boston Children's Hospital. And they have a large autoinflammatory center, as you're probably aware. And they broke down their patients in terms of diseases. And you can see here the percentages of the different diseases. So the hereditary recurrent fever syndromes that NIH has done such a beautiful job with discovery-wise, therapeutically, you can see that was the rarity in the extramural pediatric rheumatology autoinflammatory center. You could see familial Mediterranean fever still has, as it always will and always has, a large presence in recurrent fever syndromes, but PFAPA is definitely the most common seen. About 50%, about half of the patients had PFAPA, and a quarter were undefined. So I think this really highlights, from a population standpoint, at least in this one large center, what the major cohorts are that are being evaluated. Simultaneously, they looked at the CARRA registry. CARRA has a very robust registry, especially in relation to juvenile idiopathic arthritis, systemic lupus erythematosus, scleroderma, juvenile dermatomyositis. But they had because again, funding, you have to start somewhere. They had their autoinflammatory registry, and this was actually the legacy registry, so not the current registry, had two questions. Do you have that were given to the doctors? Do you have autoinflammatory diseases? If you do, which one? So very simple. And from that, Dr. Dedeoglu, Goldsmith, and Hausmann were brilliant enough to extract all these data. And that showed that still FMF was a big player in the group. Interestingly, there was a little more hereditary periodic fever syndromes. There was about 40% CRMO, which I don't know was included in the first group. So you could see that CRMO is definitely an interesting group in North America. And again, a large number of undefined patients. Now keep in mind, this may be more representative, the Boston Children's Hospital group may be more representative of what we're really seeing, because there's some selection bias in which centers were part of the legacy registry, if they even enrolled their patients in the autoinflammatory legacy registry. So I hope this came across. This is just a picture of a collarbone, very inflamed, to highlight chronic recurrent multifocal osteomyelitis. And I just wanted to briefly discuss, the amazing work that has been done in that group. It is really led by Dan Zhao in Seattle Children's Hospital. Polly Ferguson was definitely the brain trust from University of Iowa, and Fatma Dedeoglu from Boston Children's Hospital. And they did a tremendous amount of work with consensus treatment plans in CRMO. And I'm going to explain more about what consensus treatment plans are, but I just wanted you to be aware of this, landmark publication on the consensus treatment plans for CRMO that was developed by this work group. They also have this amazing registry that has a lovely name, CARRA, Chronic Non-Bacterial Osteomyelitis International Registry. And they're working through the OMERACT process to develop outcome measures and very important clinical validation metrics. They have a very strong and inspirational advocacy subgroup, and they're working on translational work, biomarker discovery, and MRI scoring. But now I'm going to switch gears to the group that we work on, and that is the CARRA, PFAPA, and autoinflammatory disease work group. And I tried to show a lot of pictures so you could feel, even in this virtual world we're in, that you could actually see the faces behind the efforts. We have a variety of subgroups to get work done. And I'm Sivia Lapidus, I lead the group as a whole. And then we have the very fabulous partnership between Karen Durrant, as you know, it's been beautifully introduced, and Fatma Dedeoglu, who run the Autoinflammatory Advocacy Work Group. And that really engages parents and families in our research efforts, really helps to make anything we do relevant and pragmatic. And we couldn't do the work we do without this huge support of this amazing effort of the Autoinflammatory Advocacy Work Group. We then have a translational work group. We try to inspire translational work. Kalpana Manthiram, who is featured here, and I know she spoke last week very beautifully on the translational aspects of PFAPA. She actually was a big player in the beginning of our group and helped to get our PFAPA CTP rolling. But now, obviously now has gone on to more translational science. And she has actually, started the PFAPA Genetics Consortium. So, we are there as her backbone to try to support her phenomenal work and others who are engaged in translational research. And then we have the very important autoinflammatory network development subgroup of our work group. And that is led by Maria Gutierrez and Grant Schuler. And they do a phenomenal job running this group, and I'm going to delve into their projects. And then the important PFAPA CTP work group, which is led by Patricia De La Mora, who's a pediatric infectious disease doctor. And I should mention that Kalpana Manthiram is also a pediatric infectious disease doctor. And Dr. Gutierrez is an immunologist and rheumatologist. So we do try to embrace multidisciplinary specialties. Also, we have the very important Nadine Saad, who's also working with Mariana Marques on the IDI validation. And she is also a co-leader of the PFAPA CTP work group. So this is a picture of when we used to meet in person. This was our 2018 CARRA meeting. And you can see we have patients, we have families, we have research associates, we have pediatric rheumatologists, immunologists, infectious disease doctors. And after a 3-hour meeting, everyone was still smiling. I just want to highlight that. Oh, sorry. So I'm going to delve right into PFAPA. I know you came to last week's sessions, you're already experts, but you know, this is a very painful disease. And I think you probably gleaned from last week's meeting that although we have therapies, we often don't know what to do when the little boy or girl comes to you with these very high fevers, chills, horrible looking tonsils, mouth sores, swollen glands. And they want to know what to do. They want to know what's right for their child. They want to know how to get better, how to resume their quality of life. So we decided that launching a PFAPA CTP was very important. We also have, they featured this study somewhat last week, but this is the largest study on outcomes in PFAPA. And although many are outgrown, there are some, you know, the average age duration of fevers was over 6 years. So this is a long time in a child's life to suffer from recurrent fevers. And it's definitely worthwhile to have a strategy. Even some, unfortunately, can persist, although it's more rare. And then there was the media that made PFAPA famous. And you can see the very famous Dr. Licamelli, who spoke last week, and he was featured in 2 major newspapers in the US because his family, his daughter, who was then 22 months, suffered from PFAPA herself. And that inspired his work on tonsillectomy and PFAPA and really expedited the need for therapeutic options to help these children. And so his own daughter had tonsillectomy, not by him, but did very well. I know Dr. Dedeoglu featured this last week, but you know, just to speak, we do have some information about potential players, you know, in terms of what is active in PFAPA, and you know, PFAPA children in between fevers and healthy kids are very much acting the same. But then with fever, they're a totally different entity. Oh, sorry. And they even differ from the other autoinflammatory diseases. So we need to figure out what to do when they have fever. Interleukin-1 seems to be a player in those PFAPA patients with flare, much higher than even the other autoinflammatory disorders. And then 5 patients were actually treated with ANAKINRA from that group that was featured in those prior pictures. And there was a dramatic response. But I must say, even though we have this wonderful proof of mechanism study, we unfortunately we did not start with interleukin-1 inhibition in PFAPA because I'll explain, but it's not the most commonly used medication. So I know they discussed the therapeutic armamentarium that we currently have for PFAPA, and that includes cimetidine, colchicine, steroids, tonsillectomy, and interleukin-1 inhibition. But we're going to jump and talk about how consensus treatment plans are formed and what the procedure is. Because I did mention that there's a consensus treatment plan for CRMO, and there are others for other rheumatic diseases, and also one for PFAPA. And there's a very specific procedure for developing consensus treatment plans. Number 1, literature review. Very important to see what's published, see what evidence there is already. Then a CARRA-based wide survey is distributed to all the pediatric rheumatologists who are participants in North America, with the hope for a very robust response rate. And this tells us the physician practice patterns already for PFAPA, because you want to develop plans that are actually used pragmatically, so that you're reflecting what is going on in the real world. Then there's many consensus meetings. And during those consensus meetings, we use nominal group technique to make sure everyone has a say in their opinion. And then there's the big vote to decide, based on everyone's opinion, the data that's out there, the practice patterns, what we're going to do and how we're going to do it, in terms of treatment. And then there's further refinement, and the survey, the plans are disseminated among the CARRA pediatric rheumatologists who are seeing these patients to see if they are comfortable using one of the plans. And then there's the final vote, and the plans are published. It makes it sound so easy, but it's multiple iterations and many, many hours of labor and tears. So finally, after about 6 years, we published, thanks to the amazing work of Dr. Murillo and Dr. Rothman and Dr. Montherum, the consensus treatment plans, and all of the many very important others who contributed to this work, because this did not happen in a vacuum. The consensus treatment plans for PFAPA, which I will jump into. First, we had to develop patient characteristics who will be treated. So we went with stringent criteria. We said what they can have. We wanted to exclude other diseases to make sure we were dealing with a true PFAPA cohort. And then we developed the plans. And either of these can be used. And the ultimate goal is that this will be implemented in comparative effectiveness research, so that the patients who are anywhere following these plans can be captured, and we can collect data on which plans are most effective, which patients respond the best, and any potential side effects. And this is what we came up with: a supportive arm of antipyretics, steroids to abort fevers, and the best way to do that, prophylaxis with either colchicine or cimetidine, and a surgical arm, which included tonsillectomy plus or minus adenoidectomy. We also, thanks to actually Mariana was a huge contributor to this effort, we developed response criteria. And these response criteria went through in all of these patient characteristics, the consensus treatment plans themselves, and the response criteria went through that methodology that I showed you. And we decided that complete response was no fever following treatment. And we developed a time course for that based on the arm that they were in. And we also were collecting other data, missed days of school, missed days of work, and global assessments from the parents on a visual analog scale. So where are we after doing this? So future directions in PFAPA treatment from this work is to develop more validated outcomes, which Mariana is going to delve into, biomarker development to know when a patient is sick with PFAPA, or what treatment may work best for them, evidence-based treatment through the comparative effectiveness research I alluded to before, and personalized therapeutics. That's really our goal for everyone, and hopefully more data will allow us to get there. I just wanted to speak to, I call this PFAPA Exploded, back to reminisce about international meetings in person. This was the last international systemic autoinflammatory disease meeting, the ISED conference in Genoa, Italy. And Dr. Montherum, presented a lot of work. I think that was somewhat inspired by CARRA. So I just wanted to highlight that. And we also, and now I'm going to switch gears actually to the Autoinflammatory Network Development Work Group, which was also presented at that meeting. So this is our picture from 2019. We got smaller, we got better cameras. I'm just kidding. And we met at our annual CARRA meeting, again, parents and families, doctors, nurses, research assistants. And we agreed by consensus that we needed a CARRA autoinflammatory network development work group. And that would be instrumental to improving clinical care, enhance research infrastructure, facilitate international collaboration, and improve patient and family involvement in research planning. We did a literature search on what was done thus far in terms of network development, and we determined that really there were significant benefits of this approach to rare diseases such as systemic autoinflammatory disorders. So that was the poster that we presented in person with Dr. Daniel Kastner, the pioneer of autoinflammation. And we presented how CARRA autoinflammatory disease network development can improve care and foster research in systemic autoinflammatory diseases. So I'm going to present what we spoke about, and these are the many important contributors. So basically, we achieved consensus because we're still working on this. It just began on the goals of the CARRA Autoinflammatory Disease Network, and that is to register North Americans prospectively, not retrospectively, create standards for quality care and standardized outcome measures, develop educational materials for patients and their caregivers, facilitate access to expert care and international collaboration. And at this preliminary time, we did have a map of the centers. We're working on expanding that map so that we will represent more of North America. And so 17 sites, and we actually did include some international sites who were part of our group, looked at some billing data, very rough data, just to get a feel of the centers who participated, how many patients were seen with recurrent fevers and different billing codes reflecting autoinflammatory diseases, including autoinflammatory bone disease. Almost 2,500 patients were identified from 17 sites. There was a lot of variability in how the billing codes were used. So ultimately, we would like to look more in detail on those patients. And there may be some variability between the billing codes and the actual diagnoses, but this was a start. And this is just a breakdown of the different recurrent fevers that were in autoinflammatory diseases that we're seeing. And Boston Children's Hospital, we keep featuring Boston Children's as a huge center. You can see that many came with recurrent fever, but then there was also periodic fever syndrome, CAPS, other specific systemic autoinflammatory disease, and chronic recurrent multifocal osteomyelitis. I'm going to skip through this because we're never going to get done. So conclusions, CARRA physicians manage thousands of patients in North America with systemic autoinflammatory disorders. It highlights the need for a CARRA autoinflammatory disease network to facilitate earlier diagnosis, education, and access to expert and multidisciplinary quality care. Future work will focus on characterizing the patients seen across CARRA registry sites. And so in 2019, just to give you, our CARRA meeting again, I'm showing the same picture. We looked at, we talked a lot about infectious disease clinics and their perspectives on autoinflammatory clinic development. We really worked on engaging parents more. We did the very important autoinflammatory disease activity index validation, PFAPA, that Mariana will discuss. We did have a project for continuous temperature monitoring in PFAPA with a special instrument that measures continuous temperatures. And we were featuring the genetic consortium organized at NIH. And we highlighted autoinflammatory network development. This is where we are virtually. Actually, there were 3 pages of pictures, but this is the one I found from our last virtual meeting. So even though we're on Zoom, the work still has to get done. So we are trying to do it. I even tried to take a picture. Of course, it's not the same photography, but we try our best. And I also wanted to feature the Autoinflammatory Advocacy Group, which also met in 2019. in person. Don't worry, this predates the pandemic. That's why nobody is wearing masks. This, believe it or not, this picture was taken at 6:45 a.m. at the meeting. That's how dedicated these families were. That was the only time there was a room available. So everyone woke up early and got together and discussed how we can engage parents and families in research, programming for families, education for families, and how to expand our group. And I know Karen is going to feature that more. And then I just wanted to show a picture of the Autoinflammatory Disease Activity Index that I know a lot of people are using in FMF, and Mariana will get into it much more. And these are the leaders of this group. And this project really illustrates the international collaboration. And I highlight our leaders, Nadine Saad and Mariana, for really embracing this international collaboration for validating this instrument. And I want to just feature, before Mariana gets started, our very important fellow ambassadors. This is a new program we have to really try to engage trainees and young investigators once the trainees graduate, because actually Nadine Saad, who got the large PFAPA CARRA grant for the IDI, she actually was a fellow and now is a young investigator. So our fellows definitely grow up very quickly. So I cannot tell you how much contributions these fellows have made in these projects. And I'm going to get into how much work they've done. But Mariana is going to take it away with the work that she's done. She's right in the middle because she's presenting. And she's going to talk to you a lot about some of the work that she's done as one of our first fellow ambassadors. And she actually started as a resident. Mariana, go ahead. I stopped sharing the screen so you could view your slides.
Thank you so much for the kind introduction, Dr. Lapidus. Let me just share my screen here. Share screen. Which screen am I sharing? No, I don't think I'm sharing the right screen. Sorry.
That's validation for IDI.
Oh, it was saying the right thing. I'm sorry.
Yes. No, don't be sorry.
Okay. So you guys can see my slides? Yes?
Very well.
So I'm going to talk a little bit about two initiatives that we had that participated in collaboration. One with the validation of the IDI, and another one that was an association with Karen Durrant and patient organizations. So first I'm going to talk about the validation of the IDI. Oh no. Okay. So we already talked about PFAPA, that you know it's a periodic fever after stomatitis, pharyngitis, and adenitis. And the reason why I started looking for another outcome measurement, because when we were developing the CTP, I was the person tasked, Mariana, do a literature review and see what validated outcome measurements we have to use as an outcome for PFAPA. And I did a lot of research and I couldn't find anything that had been validated for PFAPA. And in the end, because we couldn't find an instrument to measure all the characteristics of PFAPA, the pharyngitis and the adenitis and the fever and the sore throat, we went with days of fever. But the problem is, and that was something that really bothered me at the time, because when we were talking to patients and to physicians, the days of fever alone didn't capture the whole spectrum of disease. And some patients sometimes would stop having fevers, but they would still have sore throats and fatigue and headaches, and they would have other symptoms even without fever. So we realized we wouldn't capture those patients when we were doing research. So then I said, okay, so let's validate something for PFAPA. And then on my literature research, I found that there was this instrument called the IDI. And these are the reasons why we need an activity measurement. So we need to do comparative research. We need to know which type of treatment is going to be best for treatment. And as I said, the days of fever alone does not cover the symptoms. Patients don't have fever episodes. So we needed to see if we could compare patients who would have a mild, moderate, or severe disease. So we'd have better information when we're making the studies. So what is the IDI? So the IDI is the Autoinflammatory Diseases Activity Index. It was developed originally by the Eurofever group. It was developed for FMF, CAPS, TRAPS, and hyper-IgD. But even on the original study, they did mention that there was a potential to be used for other autoinflammatory diseases. So Dr. Lapidus already showed it, and it is basically a calendar. It's a sheet of paper that has a list of symptoms and all the days of the month, where patients can mark if they have a symptom on each day. So you can mark multiple different things that the patient could have on each flare, and then you can actually get a score that you can compare between each month, and you can have a better idea. So the idea of how we're going to validate it, we're going to see patients in clinic, and then on the month preceding the next visit, we're just going to give them a phone call. They're going to fill up the IDI, and when they come to the clinic visit, we're going to do a questionnaire, and we're going to compare the responses between what the patients mentioned that they had on the past month and the IDI score. So we're going to create some case vignettes with the information. We're going to have a panel of experts that are going to rate the disease activity between mild, moderate, or severe. And then we're going to do a comparison and see if the IDI score matches with what the group of experts is going to rate them. So our goal is to recruit 100 patients within the 2 years, and we're mostly including patients in Europe and North America. And Nadine Saad, she's now at the University of Michigan. So the main center now is at the University of Michigan. So where we are now with this project. So we already had the IRB approved and ready to enroll patients in 8 centers. And we actually did a pretty good job with the enrollment, even with COVID and a lot of issues with some centers. We have 93 patients already enrolled. We did get a large grant from the CARRA organization in 2021. So that's being helped us to fund this study. And these are our centers that currently are participating in our study. So since we're talking about the network development, I wanted to talk about a little bit of what were the hurdles in our process. So one of the things is the data sharing agreement between institutions. So even though we have 93 patients, I would love to share some data about it, but we can't because each center collected the data and we need to get data sharing agreements with the University of Michigan before we can see the results. And that has taken a long time, especially because it's COVID, the priorities for research in the institutions is not, PFAPA. So that's taking a time, but it's going to get done, but it's just one of the things that took a little longer. And another issue was how to transmit data securely from Europe to the United States, because in Europe, they were trying to see, well, if it's going to be a secure email or secure file transfer. But the IRBs from the United States were expecting that fax is a secure way of transmitting information, which Europe didn't think it was. So there was a lot of back and forth between IRBs here and there, trying to come up with what would be a secure way of transmitting information across the ocean. And finally, the IRB application in times of COVID, lots of centers had like a block of research. They could not do any IRB while COVID was going on or recruitment of patients. So that has slowed down some of the things in our research, but things are moving on. And the other part of my talk, I wanted to talk about the patient's perspectives on living with a systemic autoinflammatory disease, the impact on quality of life. So the only disclosure I have about this study is that it was done before I started at the NIH. And the objective of this study was to evaluate the impact of the quality of life of patients with systemic autoinflammatory diseases. And it was done by an online survey that was created from 2017 to 2019. It was created by patient-led organizations, including by Dr. Karen Durrant here, from the Systemic Giant Foundation, the Autoinflammatory Alliance, CAIS, and ANCA. They recruited patients on social media, and they had the survey done in English and in Dutch. The survey had open-ended and multiple choice questions, and we analyzed the data for the quality of life open-ended questions or using thematic analysis. Because the survey was done in English, we mostly had responses from English-speaking countries, most of them coming from the United States. And we did have a little bit, 5% of patients from oh my God, Thailand, like that entered the survey in Dutch. So we had a really widespread age of onset. 2/3 of our patients had age of onset in childhood, and 1/3 of them had age of onset of disease in adulthood. The distribution of diagnosis is almost kind of similar to what Dr. Lapidus presented. 25% had undefined autoinflammatory syndromes, 20% PFAPA, and the rest were the more common monogenic syndromes like CAPS, FMF, HID, STRAP, CRMO, and SWEETS, but it had 9% of other diagnoses. One interesting thing we found was that from all the symptoms listed, fatigue and pain were by far the most commonly reported, even in front of fever, abdominal pain, headaches, and other symptoms that we tend to associate more with autoinflammatory syndromes. And one thing that was also interesting was 83% of patients reported to be greatly or severely limited during the flares, which was within expected because people can get really affected during flares. But about 51% of patients still reported that they were somewhat limited even in between flares, which is not always as expected in some of these diseases that we think is something that kind of has flares and everything is fine in between. Doesn't seem to be as fine as sometimes we think. So now talking about the quality of aspect of that research. So the question was, describe how the disease affects your life. And we divided the answers that were given to that question in 4 major categories: on the physical impact, emotional impact, social impact, and financial impact. On the physical impact, there were a couple sub-themes. So lack of understanding was a big one. So patients were saying that doctors tend to disregard the diagnosis simply because they know nothing about it. A lot of people saying that the physicians didn't understand the disease, or families didn't understand. That also led to delayed diagnosis, because if physicians don't understand it, they're not going to diagnose it. So some people took 60 years to get a diagnosis. There were concerns about long-term side effects of the medications. The other concern that was mentioned was the unpredictability of symptoms, because you can be fine one day and then you have a flare the next day. So it's hard. So someone said it's hard to live a life when your disease is so unpredictable. And there was also concern of the limitation of daily activities. So both in the children, so one quote saying she's frustrated by her lack of independence and inability to do normal activities in between flares. And on the adult side, I'm an adult, but have had to move back with my parents as I'm frequently hospitalized and unable to adequately care for myself on a regular basis. On the social impact, many people talked about the inability to make plans because the flares were unpredictable and we never know when that's going to hit. So patients saying, like, we're never fully certain how to plan life, whether it's a birthday, can slip away, holidays or travel, vacations are impacted. And some patients mentioned that the excitement of a travel triggers the flare, so that makes things even more difficult. There was a concern of a lack of social life. And also a lot of impact on family and friends, because it's really hard when people around you, your family, who have a limited understanding of what's going on. And it affects the whole family. Our lives revolve around our son's health and flares. And the emotional impact was really important. So a mental health impact was reported in many patients, saying that there was a biggessed impact on the mental health with the stigma of being unemployed, the embarrassment of friends and families, thinking that you made it all up, and often condescending comments from and attitudes from medical professionals. This leads a little bit to this other part, with the difficulty of being believed. Many people saying that because people are not familiar or they don't know about the disease, they don't believe that they actually have something, even from physicians or for family and friends. Another part of the mental health issues were the constant worry about flares. So someone mentioned, I'm always worried, anxious to avoid triggers when I'm not in a flare. And there was some hopelessness and frustration. Someone mentioned, although you know a flare will come about monthly, it's still horribly disappointing every time. There's also the concern about the financial impact, especially because there was a very significant part in the United States. So medical bills and prescriptions add up, even if good insurance. And I've been unable to obtain resources to help me through a lack of diagnosis, which is also complicated because a lot of our diseases don't have FDA approval for treatment, so makes it harder for us to get insurance to pay for them. And on the other side, even patients spend a lot of money to treat the disease, but they also can't make money because they can't work, either because they miss a lot of work because their children are having flares, or because they, like if it's a patient, they can't work because of the disease. So this is a big burden for the patients and families as well. So the conclusions we got from this study was the importance to engage patients in designing the studies, because we realized that sometimes we don't ask as much about fatigue and pain as we probably should, since this seems to be a really important part for patients and families, and we don't tend to value as much when you just have doctors designing studies. Also, the real importance of raising awareness about autoinflammatory diseases, because that was one of the big concerns from the families and patients, that people don't know about it, they don't recognize, they don't trust people. And the unpredictable course of autoinflammatory disease increases the stress, and that the patients affected by the disease, even in between flares, and might need more support in that time. So this is the emails from the team from the IDI study. And I'd just like to thank all the participants on our IDI validation study. There are different centers, a lot of people that helped. And also for the patient-reported outcomes part, like our leaders from the Autoinflammatory Alliance, from the Steny J Foundation, and also some other researchers that are helping us finally analyze that data and publish that paper. So thank you very much. And I'll go back to Dr. Lapidus.
Thank you. Just gonna reshare my slides. Thank you, Mariana. That was excellent. So sorry, just trying to.
No, don't be sorry. Thank you very much.
Oh, I see what happened. I was listening to the wonderful talk, and I was my computer locked.
It
So,
was really
we're
wonderful.
good. So I have to unlock my computer. Okay. Great. Okay. We're getting there. 1 second. At least we don't have to travel, right? For this talk.
Yeah, right. That would be really difficult for us. Impossible.
No, it's okay if we have to wait a minute for the slides to share, right?
Totally fine. Worth it.
So back to our fellow ambassadors. So we heard from our featured one today. It's really incredible. You know, to move these data forward is so important, because we would never know all that valuable information if Dr. Marques didn't spend that valuable time investigating and leading this effort for both projects, actually. So now I'm going to feature our other fellow ambassadors, because otherwise we would be here, you know, till 11 o'clock at night. So we couldn't invite all of them, but I wanted to really highlight their work. I'm going to start with Leanne Mansfield and then follow with Samira Nazar Romero. So this is the work of the Autoinflammatory Network Development Work Group. This is the MARCH project. The MARCH project was inspired by COVID. At least in North America, the clinics shut down, the world shut down. You couldn't even go to a grocery store. But yet, all these patients were getting fevers. And telehealth opened up, and they were calling about their recurrent fevers. And it was inundating our clinics. So we decided that we would look at how COVID-19 pandemic has influenced the incidence of recurrent fever syndromes. So a similar approach was taken as we did in the prior study, where we looked at the different billing codes. But we looked at the different billing codes, but we looked at it relative to March 2020, which is when the pandemic started in the East Coast, at least when we could document it, at least. Through March 2021 as our one cohort, and the prior cohort was the March to the March prior, so March 2019 to March 2020, to see if there was a change. And what do you know? The new recurrent fever diagnoses pre and post COVID pandemic in 15 North American pediatric sites, you could see that during the COVID pandemic in red, there was an increase in patients. Even though there was a decrease in the number of new patients because of the pandemic, there was an increase and the number of new recurrent fever patients. And we tracked it by month just to kind of see how it varied based on, what was going on in the world. The same thing happened. So you could see there were peaks in new referrals, which was interesting, even pre-pandemic, because we do know that some patients with recurrent fevers, they'll have clusters of fevers sometimes, worse in the winter, worse in the summer. So that maybe prompts the referrals at those times of years. So that was our first piece of data. This is a map showing the centers that included data in this very expedited project. Now, we are still hoping that more centers will contribute, but I know it looks like there's less in the Midwest, but demographically, actually, this does capture a large number of patients. And basically, what we found was there were almost 1,000 new patients referred to in March during the pandemic with recurrent fevers. And even though the relative number of new patients went down, and we looked at the percent change of recurrent fever per institution, and there were some that did go down, but it's pretty impressive. Institution H had 115% increase in the number of new patients. And I mean, there were some that were only 2% increase, but, it was pretty dramatic. So we hope to get more centers, and we hope to publish this soon, so we can also justify how important the number of autoinflammatory disease patients there are out there, because I don't think we have good data on that, especially in North America, I will say. So now I'm going to switch gear to our other star fellow ambassador, Samira. And she focused on the same, similar survey that Mariana presented so beautifully, but she focused on how COVID-19 impacted, had an impact on the patients in the survey. And Karen Durrant, I should say, worked tirelessly after. I can't even explain how much work she put into the survey. So basically, it seems like there was not much knowledge on how COVID-19 affected autoinflammatory diseases. And there were a lot of unanswered questions, especially at the beginning of the pandemic. We have a disease that causes inflammation. We have COVID-19 is what I'm referring to, an infection that causes inflammation in patients who are already inflamed. So what is going to happen? Everyone was very concerned. So we wanted to see from the patient-parent perspective how COVID affected them. So it was a similar strategy of this anonymous online survey to look at how people, what their sheltering practices were, changes in frequencies of flares, and what their actual experience was with COVID infection if it was applicable. So the results of this effort showed that the frequency and the flares we have, the U.S. Canadian response, as well as the non-U.S. Canadian other country response. So unfortunately, we didn't have as many responses from them, but you could see the differences internationally. And basically, many of them increased their frequency of flare during the COVID pandemic. They also, some had no change in their flares, some were unknown, and some did decrease. So this is the number of patients and the variability in terms of what they experienced during the flare. But the conclusions were that out of 330 patients who responded, more than half reported no change in frequency of flares from their baseline autoinflammatory disease during the pandemic, which is very reassuring, I would say. So outcomes of this, of the COVID-19 in these patients, in terms of how it worked out for them, only 7% had confirmed or presumed COVID-2 infection. So that's interesting. because that's much lower, obviously, than the international incidence of COVID probably. Of those, 74%, so the majority, reported mild or moderate COVID symptoms, and they were able to be managed at home, which was very reassuring. And then we wanted to see what their symptoms were when they had COVID infection. And, you know, it wasn't surprising, actually. It was probably similar to what COVID infection brings, that they had, some had fatigue, you know, the typical cough, shortness of breath, maybe worsened asthma. They had some neurological findings, mostly loss of taste and smell, like was what was seen with the COVID-19 infection. There was some pain and swelling of the joints, new cardiac issues, kidney disease in a few, and some did have flares. There was one case of multi-system inflammatory syndrome in childhood, and the same patient actually reported that in adulthood as well. So we weren't sure, you know, so it was one patient who developed that, which is, I think, pretty good. I know it's rare, but maybe we would think that autoinflammatory disease patients would be more vulnerable. And there was some also post-acute sequelae of SARS-CoV-2. That's what we looked at. So conclusions. So while people were sheltered in place during, you know, between especially March and December of 2020, most patients had no changes in the frequency of their flares from their baseline autoinflammatory disease. Despite having inflammation from their underlying autoinflammatory disease, patients with systemic autoinflammatory diseases who had either confirmed or suspected SARS-CoV-2 infection had predominantly mild or moderate cases of COVID-19. And then so that was our project led by Samira on the COVID-19 pandemic in our patient population. So I just wanted to touch really quickly on future directions in autoinflammatory diseases. We hope that in the future, we can improve our understanding of relationships between the genetics and the clinical presentations in the monogenic autoinflammatory diseases that are more hereditary. We really need biomarkers. We need earlier diagnosis and more personalized treatment and evidence-based treatment. And of course, we're always looking to understand the genetics of PFAPA and undifferentiated periodic fever syndromes, which you can see are not represented currently by a significant amount of genetic knowledge and are a large portion of the patients seen in our clinics. And this picture was drawn by one of my patients who has an painted, drawn, who has an autoinflammatory disease and did very well. And now is a young adult. So I think we have to remember the soul behind these patients and their creativity. And I love to quote Karen Durrant's message from the Autoinflammatory Alliance of Hope. And without further ado, we will switch gears to patient education. Thank you, everyone.
Thank you very much. I should just express my gratitude before dear Karen starts. It was a fascinating talk, both your talks, dear Sivia and dear Mariana. They were very lively and very interesting and also very informative. And I'm really amazed to have known this organization with Durrant and the marvelous way in which it functions. Of course, there's a lot to learn for us there, and it can be a great start for us. And the experience that you shared is really invaluable to us. We cannot wait to hear dear Karen's speech. Thank you very much. Thank you.
Great, thank you. I'm going to share my screen. Thank you. Let me try to prop this. Okay. Thank you for this opportunity to be here. It's such an honor. And I'm here to help share some helpful resources. I have no conflicts of interest to declare. I lead our organization as an unpaid volunteer. I think the spirit of everyone is so many people are participating and helping support the efforts for these diseases and largely extra time, especially with CARRA, all the doctors and everywhere. It's been a very touching. And we have large patient groups, and I also help with rareconnect.org. That is a UARTIS initiative that has patient groups as well, but my main job is helping our patients through our organization. And I was going to share our resources. And that's me when I was little. I've always wanted to be a nurse and helping people. And my favorite title is mom. I have 3 boys, and my middle son here is the reason I came to the world of autoinflammatory, because he happens to have NOMID syndrome, which is also called NLRP3 AID severe. It's a severe form of CAPS. But he was lucky we pushed hard to get him diagnosed, and that's a different story, but I really made an effort because no one knew what was going on. He was born right when the word autoinflammatory was coming about, but he was able to enroll in a clinical trial at the NIH and start ANAKINRA, which changed his life and possibly saved it, because we nearly lost him a few times. Before starting the medicine, he had some severe things happen. And I know that in your country you have ANAKINRA, so I have a lot of hope for your patients that they can have such positive experiences if they can get early diagnosis and treatment. So some resources to help. I always recommend ISED. It's an International Society for Systemic Autoinflammatory Diseases, and their website, they have a lot more resources coming, scientific programs, and you can join and be a member and collaborate with many experts. And one initiative that is out of Europe, but is for everyone, is InFever's Registry of Autoinflammatory Mutations. And you can go there and look up mutations your patient might have. And there's a lot of information about each one and severity. I won't go there, but please this is an excellent resource. Then, and it also directs you to other major genetic data information to look at through that. So it makes it easy for you. Another resource from Europe is Printo, which is an initiative for pediatric rheumatology. And they have resources to print out for patients. It's very easy to read information, and also for things that patients can have taken to their school or explain. And they have it in so many languages. And this was, I clicked on the one for Iran, and this is the same information that would be in English. This is right here. So, that's a good resource to go to if you're trying to have something quick to hand to patients. And there's many languages. And the Eurofever project is in Europe as well. Of course, they have a big registry and has been an inspiration for much work, but their website, you can go and they have a lot of helpful information, and they have this diagnostic score button. If you go there, it brings up all sorts of good stuff. That's kind of fun. But the PDF that I'm going to show on the next page is a really a kind of a nice tool. I know we've been talking in CARRA about how to have a consistent form to help doctors to have, get information from their patients. And we also have a short form of information to give to patients that's in final production. I don't have a picture of that, but this is what the Appendix A form looks like. And you can fill this out, work on this with a patient, or a patient could even come with it. And they also have the scoring tool, which is really only validated for CAPS, TRAPS, mevalonate kinase deficiencies, and FMF, but you can put in, click things, and then it gives you a score of potential the percentage chance. Maybe you'll get lucky and find something on genetics, but I wouldn't depend upon that, but it's fun. And they have a little flow chart here that goes with that, that kind of is part of their process of how they think about patients. And so anyways, and this is our leading resource that was inspired by we have a wall chart, which some may have, and I'll show a picture of that later, but this is a database of autoinflammatory diseases and expanding greatly. We need to do more, updating more research links, and we want to have a better photo gallery eventually to represent more pictures for each diseases and variety of skin tones to represent the world, and more languages. And this is a picture of a part of it. It goes on and on and on. We have 63 diseases and it goes to the right. So, but you could compare certain features, and then you could go to hyperlinks and read the journal articles. And the search tool is, you look here on this, in that symptom search, and you can use different ways. I just I recommend don't go rash fever. You get the whole chart, pretty much, not all, but, kind of pick some specific things about your patient, put it in here, and that helps you. So here's an example: macrophage activation and fever. You just type in there, and then it brings up a list from our chart of these diseases, and you could go look at them page by page, or if you click on this view a result in a comparison chart, it brings up a custom chart for you just to compare those diseases, so you don't have to look at the whole thing, because it's a beast of information. And then this is how a view would be on us when you click on learn more over here. You will come to a single page, and you can even print this out for your patients. And we're adding more and more resources over here and links. We have a lot of updates to do, but you can read the information and also click on a button, go to the genetic testing registry, which is, sometimes there's a little delay, but if you're looking for a lab that's doing a certain test, the genetic testing registry lists everywhere in the world. And here's our original wall chart that we started with, inspired by we had a small one in our CAPS booklet, and everyone wanted one bigger. This was started in 2013 and had new versions in 2014. And now we have enough diseases to have a couple of these wall charts, and everyone would like more of them to do that. But the digital space is where we have to get things going, and we might do that. And we also have these wallet info cards, about 15 diseases that are little business card size that everything's medically edited, but these have kind of a nutshell of information, the basics about some of these diseases. And some fellows enjoy them to have a little pocket pack to look through, or studying for boards, things like that. And I was going to talk about this injection plan book in our Healthier Ever After book, which we have in 14 languages. And I'm going to show the next page. This is in the version in Arabic. It is not in Farsi, but I may be wrong, but I'd heard that maybe some could read some of this in your country. But this goes through a way to, talk to your child about, what rooms do they want to have their shot in? Where do they want to have their safe zone? What things do you like to have with it? Having a discussion with your child about what they do and do want. They need to rotate their injection sites, but they can tell. My favorite one, I wouldn't say favorite, but I preferred ones and least preferred. So you can kind of formulate ideas and how, what to work on getting them thinking about being a participant and expressing their needs, and a plan, which then leads to developing. These are pages that you can write and wipe off. It's a dry erase marker, and there's some reusable cling stickers. So they can choose making their goals, things they want to work toward, and you can change them as the child gets more, comfortable with it, like this is a, pick up my Band-Aid, and, some things are like, things I won't kick my legs while you're trying to do the shot, little things you could work towards, and little things that when they follow and achieve their goals, they could put a star, and then they have set little rewards, and it doesn't have to be fancy or expensive or anything. But if anyone is, and here's more pictures of some of the information to help patients, and we do have a PDF of the version in English, and you can email me. I put it on, let's see where, there's my email. If you'd like a copy in a bunch of languages, I can send you a PDF. I don't have them all in hand. We run our org from our home, but we have some in English, and I can direct you to where to get other copies in other languages. I know that we have some doctors, and this was a partnership with SOBI. We developed it. It is our educational resource, but we have given permission so they can help to distribute around the world to different people that need it. We have a lot of resources on our website, but we also started a blog to cover more things. This is, I don't know what your genetic testing is like or options in your country, but in America, we have a number of labs, and I did go looking around in case you are looking. I know Blueprint Genetics, they happen to have a branch in Dubai that can help in the Middle East for testing. Invitae is open internationally, but unfortunately, they cannot work with Iran. I'm sorry. Anyways, this is a table we made to help doctors to see what is and is not in various panels. And I just updated this last night to cover Vexus, because that's a hot topic for adult patients. All the Blueprint panels do come with UBA1 in it. If somebody wanted to order it separately, you can with Invitae, but so that's the good news if that's something someone's looking for. But various, depending on what you need, I don't know what's possible. Finances are a challenge globally in most places to get access to genetics. So we're trying to help people to know options, and a lot of doctors, if you have a complex patient, they're going straight for whole exome or whole genome. But if you need a panel, there are some options out there. And some other things we have on our blog, we developed, one of our board members, she figured out what people were searching for online. And so we titled some talks based on that. And we can get some months like over 100,000 visitors for certain things. We have a lot of different topics there. We also patient stories. It's a range of things. So we have to update our main website, but that's something. And as far as other resources, there's a lot online. We're trying to post our programming online. I have a bunch more to add, but you can find the 2019 symposium that we helped to participate on the NIAID YouTube channel, and also NIH video casting site. And this there's a bunch of autoinflammatory boot camp videos, and we've embedded a lot of them on our autoinflammatory search database also, and I have a lot more to add, but there was a task force working groups that came from that are where the recommendations are being finalized to be published in the Annals of Rheumatic Diseases, and will be published soon for IL-1 mediated diseases, interferonopathies, and eventually for macrophage activation syndrome related diseases. And there will be more to come. And this was had to go into a virtual space, but brought a global group of experts together. And this conference was also special because we had presenters come from parts of the world that had challenges of South America, India, to share their stories of their patients and to help develop a network beyond. It was originally to be the network, it's a translational autoinflammatory research network but it's realized that there's also more needs all over. So that's evolving. COVID's gotten in the way of everybody getting a lot of other things done. And also CARRA's efforts, we're all trying to work together to reach some of these goals. And there's definitely more works to do, but I think it's impressive that you're doing this session and helping improve awareness and education and making it free to everyone. Thank you so much. We also have Autoinflammatory Awareness Month in August. And we had a way that patients could get a little kit and share their stories and put it out there. And also building lighting happened in various places in the world to light up orange. But a lot of patients shared their message, and there's Dr. Dedeoglu right there in her clinic, and many organizations involved. It's a growing effort. It started in 2015, and we have, so autoinflammatorymonth.org is where you can find also the programming that had a lot of great doctor speakers and more. So you can go there for some of our educational sessions. And, since you already saw this, I won't share, but and one of our things we also did, we had a video this year, and I'm not going to necessarily show it unless you want it, because I don't know how much time we have, but that was an awareness video it got popular. People like videos to explain things and share with their friends. So thank you.
Thank you very much. Can I ask how much time the video takes?
It's probably less than 2 minutes.
So can I ask you to kindly play it, please?
Sure.
Thank you. Thank you very much. We just cannot hear the voice.
There you go. That was put together with a group of patients and talented people to help us, and that was a voluntary effort that was pretty impressive. Thank you.
Thank you very much. In fact, well, your talk was genuinely informative, and I dare say that we all learned a lot today. And I'm fascinated by the wonderful job that Autoinflammatory Alliance does, and its existence is such a blessing, of course. Thank you very much for all of your great talks, fascinating talks. And I have received many comments expressing their gratitude and thankfulness, and some questions. If I want to ask some of these questions, please. Is it okay? Did I ask the question? Yeah. Okay. So we have a question here that says about the CARRA network. They want to know who is included in the network regarding the physicians. Are they only rheumatologists, or are there the first-line practitioners too?
Great. And I'm sorry, did you say for like advanced practice? Is that what
Yeah,
you
yeah. The first-line
Okay.
practitioners, like physicians. Yeah.
Oh, wonderful. Yes. So that's an excellent question. So CARRA is primarily just because it's a pediatric rheumatological organization. It's primarily pediatric rheumatologists, but we really try to collaborate, if it's relevant to the diseases. So there are many, in lupus nephritis, there are nephrologists, there in our group, we have many people from infectious disease and immunology who, and now we're actually trying to, there's a new member who is a geneticist and an adult rheumatologist. So we're trying to recruit experts from a variety of areas. We also had the otolaryngologists, Dr. Licamelli and Dr. Props actually are part of our group because it's relevant to the care, and that's how we developed our CTPs as well. But that's true in other groups as well. So for instance, in localized scleroderma, they work with radiologists, dermatologists, and developing, better measures of chronicity and activity. So it depends on the group, but it is primarily pediatric rheumatologists. Also, allied health professionals are invited as well. And they try to embrace research assistants as well in the process. And families, most importantly.
Great. Great, thank you very much. And I also have another question here. They have asked, in the market study, what types of periodic fevers increased during COVID?
What type of periodic fevers increased during COVID?
Yeah,
That's a great question. Unfortunately, we didn't break it down in the same way because it was billing data. So we wouldn't be very representative since our billing codes in the US actually don't reflect the granularity of different autoinflammatory diseases, unfortunately. I think PFAPA is the main one that we've seen, but that is personal opinion and not based on data.
yeah, great. Thank you. Thank you very much. And Dr. Sadeghi had asked something here that Mariana kindly answered fully. Yeah, thank you very much. And there is another question. Can people get joined to help with developing data for patients and PDFs in different languages? For example, can Iranians join to help with Farsi?
Oh.
Is it possible? I think Karen knows it better.
Yes, that we're always welcome. Are you wanting for patient materials or for for the Printo resources or for our search database? Please do email me. We would be happy to collaborate and help get more information out there.
That's great. That's fantastic. Thank you. And I have another question here that I asked about the pathophysiology of increasing autoinflammatory disorders. Do you think it's related to interferons?
Did you say, I'm sorry, I missed the last part. Is it related
to interferons?
Oh, to interferons. That's a wonderful question. Yes. Basically, unfortunately, we don't know why. There's different speculations. It seems that it may be that people are sheltering at home, so they're recognizing the fevers as inflammatory because they're not exposed to fevers. In terms of the mechanism, it's interesting because all of this time we kind of had this long decades of debate whether PFAPA was related to infection or non-infection. I think it actually shows that with less exposure to infection, there are more flares, which is a fascinating concept. So I think we could probably spend another 5 hours discussing the potential mediators of that mechanistically, but it could be that interferon plays a role, because probably interferon plays a role in PFAPA in general. And that gets back to my point in biomarkers. If we had a good biomarker, we probably could look better at the mechanism of these phenomenon. And I think that's really the key, is more translational science in autoinflammatory disorders to answer these very important questions of mechanism.
Yeah, great. So I just should say that when Karen was playing the video, I thought that it did not have a voice because nobody said anything, and I think it was okay. But now I got that it had a voice. So if she can kindly replay it, we will be honored. Thank you very much. Because it was really beautiful. Yeah.
I'm so
Thank
sorry.
you. Thank you very much.
I didn't think
No,
about
it's
it.
okay.
I'm not technologically gifted on the Zoom
Oh,
world.
you're great.
Yeah, but I will do that right now, and hopefully you can hear it. And I will be watching comments too. Hang on.
Thank you. Thank you very much.
Thank you. Okay, let's see here. Just going to try to make my screen bigger, I think.
It's great. It's good. Thank you.
Autoinflammatory diseases.
Can you hear it? There you go.
Yeah, great.
Okay, I'm gonna back it up and start now.
Autoinflammatory diseases. No, not autoimmune. Never heard of it? That's okay. Many doctors haven't heard of them either. Classified just over 20 years ago, autoinflammatory diseases affect the innate part of the immune system, with patients suffering from periodic fevers, rashes, inflammation, and other even more hidden and at times deadly symptoms as well. With few doctors around the world with knowledge to diagnose, let alone treat these diseases, patients feel alone and in the dark, trapped, and unable to find a way to health and happiness. But they don't have to be alone. For International Autoinflammatory Awareness Month, we're calling on everyone to shine a light into the darkness. By shining a light on autoinflammatory disease, we can bring awareness for thousands of people worldwide suffering from these diseases. With awareness comes diagnosis and treatment. And then comes research, education, understanding, and hope. This August, shine a light on autoinflammatory disease.
There. I hope everyone heard it this time. Thank you.
Yeah, it was great. It was really touching, and the message was very beautifully conveyed. Thank you very much. Thank you.
Oh, you're welcome. And we had it translated to Spanish and Ukrainian by some. And so if it's something that anyone wants to do a translation, we are open to that as well. So thank you.
That's great. That's great. I think we will be in contact. I'll be honored to do that. Yeah. And I should sincerely thank you for your great presentation, and Dr. Lapidus and Dr. Mariana, of course. It was a really informative lecture and a great session. And we are honored to have had you here today. And I hope we can have future collaborations for patient education and for the networks that we have talked about so much today. And if there's anything you want to add, I will be really grateful to hear that. We all will be.
No, this is such an impressive series. We're truly grateful. This educational effort is so important. for the future of autoinflammatory diseases. And it's so lovely to be part of an international community. That's the silver lining of Zoom. So it's really an honor.
Thank you.
Thank
We
you
are
so
honored.
much.
Thank you. Thank you. And the honor is ours. Definitely. Thank you very much for being with us today. And just let me thank the audience too for participation in the session of How I Treat Autoinflammatory Disorders course. And I hope that you have had an enjoyable time. And you should know that we will share the post-test later with the participants, and then we can send a certificate. As I mentioned before, the certificates are approved and validated by APLAR, Pediatric Rheumatology Society of Iran, Iranian Rheumatology Association, and Tehran University of Medical Sciences. We also had Dr. Dedeoglu here. I'm truly honored to have had her today with us. She has helped a lot in coordination of the sessions, and if we could have her for a few moments even, that would be really great if she can talk with us. Yes, great, thank you. Hi Fatma, that's such an honor to see you here today. We don't have your voice. Dr. Dedeoglu, we do not have your voice.
I think you're muted, Dr.
Yes.
Dedeoglu.
All right, sorry, because I wasn't allowed to unmute. Hi, everyone. This is really exciting. It's just like
So great to see you.
as you know that I'm into all collaboration, getting everyone together, and you know let us do that. And thank you for involving me to be part of this. And I also thank all the you know Sivia, Mariana, and Karen that they gave their time, and I really appreciate. And all the you know audience that's spending their time with us, and all the nice, very excellent questions.
Thank you very much. You have helped us a lot, and I'm truly grateful towards you. Thank you. And I'm so happy to see you again today. Okay.
Great.
Thank you. And we invite you all to our next session, which is going to be held next Friday, entitled as NLRP3 from autoinflammation to metainflammation. You can find the details on the next sessions in our website, and you can see the link in the chat forum. Also, we will be very grateful if you can fill in the feedback for be shared in the chat forum. Thank you very much and have a great day. Thank you again, dear Mariana, dear Karen, and dear Sivia, and dear Fatma. Such an honor.
Thank you, Kosar.
Thank
Bye.
you.
Thank
Bye.
you.
Have a great day.
Bye, everyone.
Bye. Thank you.
Thank you. Thank you very much. Bye.